Okay, thank. Anup, can you hear me?
Yes, ma'am, audible.
Yeah, okay. So very good afternoon to all. Happy to see you again. Today we are going to learn about wound management. So we have seen two different types of wounds in palliative care. Mainly we have seen two different types of wounds in palliative care. One is pressure ulcer and the another one is fungating wound. Today we are going to learn about wound manage that pressure sore. Uh, uh, this will be taken by Sister Anna Daniel Rao. She is a BSc nurse. She did her certificate course in palliative nursing from Pallium, India. And also she did her fellowship in palliative nursing from Institute of Palliative Medicine, Calicut. She has around 10 years of experience in cardiac field. And also she was the nursing head there. And now she is working as a nursing tutor in Institute of Nursing Science and Sri G.H. Patel School of Nursing, Gujarat. Um, she has 16 years of experience of that also. She is a well-versed person in this field. Sister Anna, welcome and over to you.
Thank you very much, Mr. Shiva. I'm very much privileged to share my knowledge in palliative care. And together we can do a great job to relieve suffering. That's what is our motto, right? And I'm very happy to see many young people joining this course, and happy to see that we can share more and more knowledge and sort out the problems that are suffered by the patients in palliative area. So let me take you directly to the presentation. Today we will have the first session on wound management of pressure sore. Okay, all of you must have seen pressure sore, but in particularly if we talk about palliative care patients, we see small to very large bed sores. Okay, and that are very much preventable also. Okay, so let us move to the definition and causes and what else we can do to prevent and to treat also, right? So what is wound or what is bed sore? Okay, so here the patient gets sore when the patient is in bed. So sometimes it is said that, okay, when nursing care is not good enough, they tend to get developed. Okay, so it is basically injury to skin and tissue lying beneath, and mainly caused by unrelieved pressure. Okay, so why it is so important? So our sole purpose of palliative care is day-to-day care, but along with it, by our care, the patients must receive maximum comfort. Okay, so you can imagine a patient lying in bed who is not able to do anything and is getting a sore over the body part, and that will make him very much uncomfortable. So naturally, it will go against our principle, right? So, and the patients who are receiving the care in this palliative setting, they tend to develop pressure sore for very easily also for many reasons. And most of the causes we know, right? But let us not forget the basic causes. Namely, first is the pressure, right? So when the patient is lying in bed since long time, he will get it easily. Okay, so it is said that it takes only 6 hours to develop pressure sore, okay, or to start pressure sore. Okay, but takes very long time to heal, right? Because of the very nature of our patient's condition. and it is a major cause of discomfort also. Or in other words, you can say that if the pressure of 70 mm of Hg, it is exerted over body parts for more than 2 hours, that can cause tissue destruction. Okay? And that can lead to pressure sore and other complications also. Second cause is friction. Right? So that will cause abrasion of stratum corneum. And here the skin rubs against, it can be very fundamental things like clothing or bedding. Okay, we'll talk later about the other equipments that are used for the basic nursing care of patients, like bedpan, or you can say anything like Macintosh or like anything. Other major cause is shear force. So here what happens is that the force is in two different directions, okay, in opposite direction, and the surfaces would be parallel to skin. Okay, so because of this, also a patient can develop pressure sore, and all these things we all believe that can be preventable, right? So that is of utmost importance that by our tender loving care, our education to the patients and relatives, pressure should not happen. What can be the risk factors? And most of these risk factors you will see in our palliative care patients, right? So these are just to name a few. They are impaired sensory perception, okay? Impaired physical mobility, conscious level is altered, patient is not able to know what is happening to him. Fecal and urinary incontinence, you might see in many patients you are carrying. Altered mental status also, including delirium and dementia. They don't remember what they are doing, how it is happening, right? Like that. Other causes are like malnutrition and dehydration, edema, anemia, hypoxia, hypotension also, right? All will lead to lessened circulatory at minor level. Okay, at very minute level, capillary level, it is disturbed, and because of that is happening. Even excessive body heat that will dry off the tissues and cause many problems. Advanced age, we all have our grandfather, grandmother in our house. Everyone has that person in the family, and they too get many problems at the later stage due to one or the other reason. So they are also at the greatest risk. And all, of course, other problems like diabetes and cardiovascular diseases, we see plenty of them in our society, right? So that can lead to many complications, and that can lead to development of bed sore in them. So what is pathophysiology? All these risk factors, okay, they will act on the area, may not be all together, but to name a few, one or two, say for example, and that what will happen, they will destroy the soft tissues that are especially over the bony prominences. Okay, so when the pressure exceeds normal capillary pressure, that can be very small, and what will happen later, it will occlude, or it can even tear off small blood vessels. Okay, and because of that, what will happen, the tissues which are supplied by these tiny blood vessels, they will be deprived of their oxygen and nutrition, right? And because of that, necrosis will take place. So that is what we name as pressure sore. So let us not forget the stages. We all know, and at one or the other point of time, we might be observing in patients. So basic things we will not forget. So stage 1, what it happens here, there will be erythema. Okay, the local area will appear pinkish in color. So warmth also may be found there. Edema also may be present, and pain also may be there. So that will indicate at risk person. Whenever we find such person, always there should be alarm ringing in our minds. Okay, and action plan should immediately be in place. So that will involve only epidermal layer of skin. Okay, stage 2 is named as partial thickness. Okay, and many times blister also may develop. Okay, so here what you will see is that there will be shallow open ulcer with red, pink color. Wound will be there. Okay, there can be slough, there cannot be slough, and the layer here, epidermis and dermis are involved, and ulcer may be referred as blister or abrasion. You can see in the figure here, and picture also is there, and it is also very painful to the patient. Patient may be able to tell you that it is painful, may not be able to tell you. So what is important is the assessment. Stage 3 is called as full thickness ulcer. Okay, so here all the layers, the subcutaneous fat may be visible, but till bone and tendon or muscle is not exposed. So here you can see in the picture. Okay, so that is third stage, bed sore. Okay, so what has happened? All the layers of the skin, epidermis, dermis, and subcutaneous tissues are involved here. Okay, and because the subcutaneous layer is very poorly supplied by the blood vessels. Okay, so this stage becomes now difficult to get healed. Okay, and very soon it can lead to stage 4 bed sore. Okay, and we may see necrosis of subcutaneous tissue also. Stage 4 is called full thickness tissue loss. Okay, so here you can see that muscle, tendon, or even bone will be exposed. Okay, so breakdown is quite large, and supportive tissue is also lost here. So it may become very large and very, very difficult now to revive it, okay, or to get it healed. There is also another stage that is known as unstageable. This occurs because the wound will be covered with eschar, there may be pus formation, and the view is not clear. Okay? Depth will not be known. Okay? So it is very hard to diagnose. Okay? So once it may appear even greenish in color, yellow in color, or blue, black also, because of extensive tissue damage. And many times such patients will require surgical help also, right? So that is unstageable stage. Now, because of this, many complications tend to develop, right? Like cellulitis, okay, inflammation of soft tissues will take place. Then the infection will be directly now going in the tissues. They can enter in the bone, they can enter in the blood vessels. Okay, joint infections can take place, deformities will take place, patient can go into septic shock also, right? Many things can happen. Okay, so we want them not to go into complications. Okay, so always we as nurses will not be available for patient care. So whoever is taking care of the patient at home, Okay. So the carer's education is very, very important. Okay. Always involve the caretakers in the not only the care, but also tell them, educate them, so that from them we also learn many things, many problems can be sorted out, and we can get the solutions. Okay, so the sole aim should be to relieve pressure and prevent further complications. So let us move how to take care of the uh, skin and pressure points. Okay, so first is general hygiene. What to do for general hygiene? Okay, so changing of the position, daily care of the uh, patient, hygienic care of the patient, providing wrinkle-free bed, bed linen should be such that no more wrinkles are there. But that becomes very, very difficult when patient is moving in the bed, right? And patient is in the bed 24/7. So avoiding shear and friction, especially when we are either changing the bed linen or changing their clothes, right? So regular inspection of all the pressure points is very, very important. So if we talk about skin care first, then the skin of the patient should be supple. Okay, so that should not get dry, and it should have proper moisture in it. Okay, so that is why in palliative care we avoid using talcum powder. Instead, we use moisturizer. Okay, and what kind of moisturizer can be used? Anything simple that is available in patient's house, right? Like coconut oil, right? So that will be very much available. Vaseline also will be available, right? So these, and they will also be cheapest sources. Okay, so we also need to remember economic condition of the patient. So instead of going for rather fancy products, we should try to do the skincare with whatever is possible in the house. Other thing is changing of the position every 2 hourly, right? And along with physiotherapy, a patient should also get recreational therapy, diversion therapy, and occupational therapy. That will also help in giving good nourishment to the skin. Okay, so these are the pressure points. Okay, you must have learned about it, right? So when the patient is in supine position, what are the pressure points? It can be back of the head, scapular region, over the shoulder, elbow, buttocks, and heel. Okay, and when the patient, you are turning the patient on the any lateral side, whether it is left or right. So what happens? The pressure source can develop at on the ears, right? Lobe of the ear also they are tend to develop. Then uh, shoulder, elbow, hip region, right? And our patients will be very skinny most of the times, right? So they are very much liable to get pressure sores. Even thighs, okay, rubbing of knees, leg over the heel, okay, and when the patient is on abdomen, okay, prone position. So here also patient will tend to get develop pressure sore over elbows, rib cage, thighs, knees, toes. And what about the patients who remain in wheelchair for a long period of time, right? So they tend to develop pressure sores over shoulder blade, then in the sacral region, coccygeal region, ischial tuberosities, right? Posterior knee, right? And feet. So whenever patient is in bed, we try to change the position every 2 hourly during daytime. And what about night, you will ask, right? So when patient gets up for any taking a glass of water or anything, then at that time you can change the position. So once in night. And when the patient is chair bound, wheelchair, right, at that time, every 15 minutes, it is important to change the patient's position, right, in the form of some movement. You can make the patient sit, lean forward, go backward, right, like that. And you can use soft clothes, pieces of soft cloth to prevent any hard areas that are rubbing against the chair. Gentle massage is always recommended. Okay, and pressure points, and especially when it is already damaged, they should not be massaged. Passive stretching of each joint at least 10 times twice a day is very important. That will help in preventing other problems also, like atrophy of muscles or contracture of the joints, and even development of deep vein thrombosis. Okay, so that also will take care of. Then positioning of pillows, what it should be. Okay, always when the patient is in sideline position, always place soft pillows, or if nothing is available, then soft clothes can also be there. Okay, you can make pad of soft clothes and then place in between the knees, in between the heels. Okay, that can be done. So padding of bony prominences is very, very important for protection purpose. All fancy equipments are available, right? Nowadays, even at cheaper rate, they are available on rent also. Okay? And many patients, they are affordable, they can buy also, right? So air mattress is there, water mattress is there, where they can be used at home situation also. But that one thing should not be forgotten, that these equipments are not the final solution. Okay, you always need to take enough care, change of the position, lubricating the skin is always should be done. Okay, so what it will do, it will help in spreading the weight of the body equally. Okay, and in that way, it will prevent pressure sore. Okay, but not to forget, not to stop the care of the patient. Okay, so with proper treatment, most of the pressure sores heal. Okay, and we can prevent them leading into further stages, like stage 2 can be prevented going into stage 3, and stage 3 into stage 4 and all that. Okay, so healing will depend on what? General health and diet of the patient, right? And relieving pressure on the sore, and of course careful cleaning and dressing of the sore. So how to go about that we will see. Whenever we are cleaning, irrigation should be done by normal saline only. No use of betadine or hydrogen peroxide for cleaning purpose. They will do more harm, more irritation to the soft tissues. Okay, so that will harm more, give trouble more to the patients. Whenever required, surgical removal of dead tissues and scabs should be done very carefully, because then that should not harm the newly growing tissues. Okay, so that care should be taken whenever we are cleaning the bed sore, doing the dressing of it. Use of moist dressing material, okay, that is very important, because that will prevent damaging of granulation tissues. So when we want to change the dressing, what will we do? First, we will soak the dressing. So ideally, you can tell the patient to take good bath. Okay, so are talking about the care of the bed sore wound, right? Okay. Yeah, so when we are doing dressing, we need to remember that that should not, the dressing material should not get adhered, right? So we want to submerge it in, or tell patients to take good bath, and it can be removed easily, right? Or otherwise you have to pour normal saline over the dressing material and loosen it. Okay, so that there should not be any stretching of the skin or like that, because it will also harm the newly developing granulation tissues. Okay, so that is our sole purpose. And also it should not, our procedure should not give any pain to the patient, right? So what to do extra thing for that, you can give the painkiller, whatever analgesic is going on, to the patient just 30 minutes before the dressing time, or set the dressing time in such way that it comes after the 30 minutes of patient's regular analgesic dose. If patient is getting morphine, then you can give even extra dose of morphine tablet also. What else can be done? Good nutrition is also another key to healthy development of the uh, granulation tissues, right? So a healthy diet that is rich in protein and vitamins should be given to the patient. Vitamin C is also another good source of healing. Vitamin E is also good for skin, right? So we should provide the diet, and at that time we need to remember that again the sources should be locally available. Always whenever we give health education to the caretaker, to the patient, always remember that find out the local sources of whatever is needed for the patient. So that will restrict the economical burden also, because here the patient alone will not be there in the house, right? There will be other people who need, like say for example kids are there, then they would be studying, right? So money is needed for them also, right? So all the resources of the family should not go after one person only. That needs to be remembered. Adequate hydration is also very, very important for skin integrity, right? So it should be seen that patient is getting enough liquids, enough water throughout the day. And if the that many times this becomes difficult when the patient is on Ryle's tube feeding. Okay, so this should be taken care that along with the food, water is not forgotten. What lifestyles changes? Many of our patients are having bad habits also, like smoking, tobacco chewing, like that. Okay, so they have to forget that or leave that uh, bad habit, because what will happen is that the nicotine in it will harm the, it will hamper the inner layer of the blood vessels. Okay, and that uh, makes it to clot, right? So, and also development of healthy tissues will also get hampered, right? New blood vessels circulation will also get hampered. So this should be taken care of. Then exercise, daily exercise improves circulation. So just we saw in previous slides that the patient should be given some movement. Okay, if not possible actively, then passive movement always need to be helped out. Recreational activities is also very much helpful. So in that context, it is important. It will also prevent contractures that we had just seen. Controlling incontinence by using appropriate measures should be done, like use of bed sore or use of soft clothes. Uh, use of the nappies or soft clothes can be done. Diapers are also good source, but many times patients cannot afford them, right? So always need to see to it that whatever is handy in the family should be used. If patient has urinary incontinence, then catheterization should also be done. When the wound becomes infected, naturally antibiotics will come into picture, right? So our responsibility is in giving good, that patient should receive the drugs timely. And if patient is at home, then caretaker should be asked to do so. So education of caregiver in that sense also is important. Many patients do require, especially those are having very bad bed sores, they require surgical repair. So here our responsibility will be in pre-operative care and post-operative care, right? If the patient is having getting surgery and having tissue flaps, then that kind of help should be done. Okay, plastic surgery may be required to replace the tissue. So in that graft or anything, right, that should be done. Other treatment options are also available nowadays. That is hyperbaric oxygen. So they are used for tissues which are starved of oxygen. Okay, so here the part where the wound is kept supplied high pressured oxygen. Okay, so oxygen tent can be used, or the part can be placed in small chambers with high pressure oxygen. So that can be used. Topical use of human growth factors are also good option. Okay, and negative pressure wound therapy to suck out the uh, infected material and all, that is also used. Uh, then when there is odor, bad odor is coming out of the wound, at that time Metrogyl tablet powder is sprinkled over the wound. Okay, so here we advise the patient to keep the Metrogyl tablet powder, crush the tablets and place, preserve it in airtight container. Okay, so whenever the dressing is to be done, so at that time, after cleaning the wound, they can sprinkle the powder over the wound. Okay. Then for removal of HR, it can be dipped in uh, one simple solution can be used, like white vinegar. 1 ml is mixed with 9 ml of normal saline, and that solution can be used for this purpose. So you need to dip the dressing material, gauze piece in it and keep over the HR. Okay, so in few days time, it will get removed. Daily you have to do the dressing. Okay, rest of the part you can see wound here. Okay, so rest of the part can be the same method, like if you are applying, say for example, Metrogyl powder, that can be placed. Okay, that can be sprinkled, or Vaseline gauze can be placed. Okay, only on the HR you have to place the dressing material that is dipped into vinegar and normal saline. Okay, so that way it can be done. And use of papaya leaves are also done in many village parts, rural areas. Okay, raw papaya can also be used. What you can do is thin slice of papaya can be placed, or if the, when especially when the wound surface is even. Okay, otherwise what you can do is smash it. Leaves or raw papaya can be smashed, make a pulp and apply over the wound. Okay, and aloe vera pulp is also good. So here you can cut aloe vera leaf and remove the top and bottom skin, and whatever pulp is coming out, that can be applied directly over the dressing material, and then the dressing material can be placed over the wound. So that also helps a lot in healing the pressure sore. So let us summarize this session. What you need to do first and foremost is do the assessment. Okay, you must have learned assessment in total pain assessment, looking at the physical problems of the patient, psychological problems of the patient, social problems of the patient, and not to forget the spiritual part of it also. Right? So after assessment, you will prioritize your needs, patient's needs, what he requires, right? And of course, when the bed sore is there, that should be of your utmost priority, right? So do good assessment, right? Skin condition should be observed at least twice in a day when you visit the patient. Okay? Each pressure site, when you are doing the dressing, at that time also you can see the pressure sore if it has developed. And before that, if there are any changes, say for example, it feels more warm compared to other part of the body, okay, or it has changed the color, okay, so all sorts of observation you need to do. Any dry skin is there, moist, too much of moisture is there, why it has occurred, any breakage in the skin has taken place, how much patient is mobile, what is the circulatory status, what are his peripheral pulses. That is very, very important. Always check peripheral pulses, posterior tibial, and that you have to check whether they are good or not, or there is any hampering has taken place or not, like that. Edema, if patient has developed or not, right? Neurovascular status is of course very, very important. Presence of incontinence is there or not, how much nutrition patient is getting, is he taking good amount of proteins or not, proper energy levels are maintained or not, enough or not, right? All that we need to assess. Other health problems, if the patient is having comorbidities, okay, that also need to be assessed. Not to forget pain assessment. Okay, we can always use this Braden scale also to identify the patients who are at risk of developing bed sore. Okay, so here all the parameters you can see: sensory perception, whether it is completely limited, very limited, slightly limited, or no impairment. Right? Accordingly, you have to place the number here. Okay, so say for example, slightly limited, then you place 3 over here in the box. Then moisture, whether skin is constantly moist, okay, often moist, occasionally moist, or rarely moist. Accordingly, you place the number. Okay, so similarly, you can do other fields of assessment also, like activity, mobility, nutrition, friction, and shear. Okay, so after placing the numbers, you will do totaling of it. Okay, so you will find out the what is the risk where your patient falls. Okay, whether he is at extreme risk, then it will, your score will be less than or equal to 9. If he is high, if your score is 10 to 12, then the patient will be at high risk. Okay, if the score is 13 to 14, then patient is having moderate risk. Okay, and patient will be at mild risk if the score is 15 to 18. Okay, so accordingly we can find out. Okay, so all the interventions I have given here under the nursing diagnosis. So what you can do, interventions for patients who are having less sensory perception. So what to do? Then for patients who are having incontinence, okay, either urine or stool, then what to do? Okay, and what to do to avoid friction and shear. If patient is having less activity or less active, patient is not mobile, then what to do? Yeah, and if the patient is having poor nutrition, what to do? So these all points we have already discussed. These are just a kind of summary what we can how we can help out the patient. Okay, so evaluation is important, and next step depending on the evaluation is very much helpful, and not to forget the documentation, because for nurses it is very very important. So with this I will end my presentation. If any queries are there, we can take up.
Thank you, Anya, for the wonderful presentation. Anybody have any doubts on this, please ask her. Or you can put your questions in the chat box too. No questions. I think your presentation is clear to everyone. Anybody? One question: which solution is best to clean the wounds?
Yeah, anyone remembers? Which solution is best to clean the wounds? What did we talk? Which are the solutions that are, yeah, okay, normal saline, right? So how to make it at home? Or patient is asked to always buy it from pharmacy? Yeah, white vinegar and anise in case of SR. Yes, boiling water with salt. Yes, good. So you can always advise to take 1 liter of water, clean water, add how many spoons? 1 spoon or 2 spoons? 3, 4 spoons. Yeah, there is tie 1 or spoon or 2 spoon. One spoon, right, Shiba sister?
Yeah.
1 liter, 1 spoon.
No. For normal saline, for homemade saline, you can take 500 ml water and add 1 teaspoon of salt. If you take 1 liter, then you can add 2 teaspoon common salt and boil it for 5 to 10 minutes. Then you can use for that. So normal saline is the best solution for wound cleaning. Any other questions? Okay. So I think
we had one question.
Yeah.
Was going on. So how to help the carer to cope better with the 2 hourly journey. Most of the carer will experience carer fatigue. So I think that's
Sri Priya, can you read once again?
how to help the carer to cope better with the 2 hourly journey. The position change.
Okay.
Most of the carer will experience fatigue with that. So how to handle that? How to help the
Okay.
carer to overcome that? Just ask
Anya?
Okay, so care
Yeah.
naturally 24/7 caretaker is taking care of the patient, so he also needs some rest. You are right. So how to go about it? Fatigue, no, exhaust. A relative will also get exhausted. So getting help maybe from the other family members. Then many times turning of the patient, especially when the patient is very heavy at that time, backache and all things also can happen. Okay, so what you can do is use of the bed sheet or draw sheet can be made, okay, which are already spread extra below the patient. So with the use of those sheets, you can turn the patient, not like that. To take help of other person if available, that can be done. And that is why always you have to encourage uh, caretakers by telling them encouraging words whenever you are meeting them, because without their help we are not going to achieve the uh, our result, right? So they always need good encouragement.
Yeah. So yeah, this is we always says palliative care is not only for the patients and for the family also. In this case, you can just imagine a bedbound patient, the caregiver, how much effort she or he will do for this patient. So, without one important thing we should remember always is without caregiver support, we can't do anything. So, we need their support. And also, if we need support, how can we build a rapport? That is also very, very important. We always say, like, you should do like that, you should do like this, you should turn the patients, you should do the dressing, you should apply moisturizing agent and all. So, if instead of you can just start the word, use the term we can do what we can do for these patients, we can do together, so then they can feel some, okay, somebody is behind them to help them, that kind of thing will be there, they will be thinking like that. Okay, so you should just start the word use of we instead of you, we always use you, so that time they feel that okay, they are alone. And that is the first thing we can do is, and another thing is, after that also you can just educate the caregivers, uh, and also if possible you can demonstrate them, so they don't know how to change the bed sheets for a bedbound patients. If you do, if you tell them, they will understand few things. If you demonstrate them, definitely they will remind all the things, they will remember. Okay, that also important. And the another thing is, um, if the caregiver is too much, that may be some uh, fatigue there, so that time what you can do is you can connect a local palliative care teams, or maybe local hospital. So some places that refractory service, like the we bring the patients along in the hospital, so our hospital staff will take care of the patient. That time the 1 or 2 weeks that caregivers will be free, they will be able to go anywhere, so that time they will be free only. So that the 2 weeks or 1 week, the patients will be treated by the hospital with the support of the nurses or doctors. So that kind of thing also you can think about that. But what you can do first, you can do is you can connect a local palliative care team with that patients, so that maybe volunteers will go there, and in between they will go there and they will support the caregivers. That time they will be free. Otherwise the relatives and neighbors will come and blame them. Okay, so that is also affect the patients emotionally. So if possible, you can connect the local volunteers and connect, if there that volunteers there, they can also go and talk to them. So we can prevent isolation also, if they are able to go in between to the house and talk to them and support them. That kind of things we can do. Okay. Any other questions?
No, ma'am.
No. So before moving to the case presentation part, I would like to highlight few things because in palliative care, we have seen lot of bed-bound patients. They are usually, they will be getting pressure sore very easily because they are bed-bound. Most of the time, the caregivers and the patient doesn't know how to develop pressure ulcer. So what you can, whenever you have seen a bed-bound patient, you have to tell the caregivers about the pathology, pathophysiology of pressure sore. So that also they should understand. Then only they will give much important for that changing the position and all. And also before discharge, if the patient is maybe for a bed-bound patients, if if you are planning to discharge, before they go home, you have to educate them well and demonstrate them. So the caregivers, the preparation is very important. And also you have to remember double SKIN. The first, whenever you have seen a bed-bound patients, the first S is you have to think about a supporting surface. Whether the patient is having a good supporting surface, you have to think about the air mattress, water mattress, that kind of things. But and one important message you have to convey with the caregivers is the air mattress or water mattress is only the supporting surface only. Okay, even if the patient is on air mattress or water mattress, they have to change the position. Okay, this is not a 100% preventable measure. And the next X is skin inspection. Whenever they have turned the patient from supine position to side laying position or side laying position to supine position, they have to give a special attention on the pressure points. If there is any color change there, we can give that special attention on that area and prevent further pressure on that area. And the next thing is K. K is keep moving. Every 2 to 3 hours, they have to change the position. And the next one is I, incontinence, incontinence control. If there is an incontinence there, we know the moisture is one of the major cause of pressure ulcer. If there is an incontinence there, the patients will get pressure ulcer. So if there is incontinence, you have to tell the patient about maybe if they are willing to put a catheter, you can put a catheter. Or if they are not willing to put a catheter, then you can think about the diaper. If they are not affordable, you can think about this the linen, soft cloth, cotton clothes. But you have to tell them, if the linen is wet, they have to change it as soon as possible. And the last one is nutrition. Nutrition and hydration is also very important. Protein intake, the lack of protein intake in their diet can cause pressure ulcer. So these are important things you have to keep it in mind. And whenever you have seen a bed-bound patients, you have to educate the patient as well as the caregivers about prevention of pressure ulcer. Okay. So I think we can move on to the case presentation. Sony, over to you.
Good evening, everyone. My name is Soniji. I worked as a staff nurse in Anandaburi Hospital. Now I'm not working. I'm going to present about the case history of my old patient. Next. Next. Patient details: 56 years old male. Diagnosis: paraplegia with stage 4 pressure sore on the sacrum, secondary to immobility and diarrhea. Presenting complaints: 56-year-old male with complaint of pain due to stage 4 pressure ulcer on the sacrum, complaint of tenderness on bilateral greater trochanter, reports unable to ambulate without assistance, mostly wheelchair bound, poor nutrition due to decreased oral intake, unable to move himself, needs complete assistance to get out of the bed, diarrhea for 3 days, generalized weakness present, feels depressed due to disease process, immobility, poor healing, pressure ulcer, also disturbed sleep pattern. History of illness: 56-year-old male patient met with a major accident in 2000, which resulted in cervical spine C2 C7 injury. He lost all sensory and motor functions of hip and lower limbs, that is paraplegia, and partial loss of motor function in upper limbs. He also had right clavicle fracture. Now presented with complaint of stage 4 pressure sore on the sacrum, secondary to immobility and diarrhea. Onset of ulcer 2 years ago. Character: mild burning like. Pain: bilateral trochanter area. Pain also present constantly throughout the day. Associated symptoms: numbness in surrounding area. Medical history of type 2 diabetes mellitus since about 16 years. Complaint of diarrhea for 3 days on urine drainage bag since the accident. Examination: patient conscious and oriented. Vital signs are stable. Temperature 98°F. Pulse rate 76 per minute. Respiration 26 per minute. BP 130/80 mm of Hg. Saturation 98% on room air. Respiratory system: no cough, dyspnea or wheezing. Cardiovascular system: no palpitation, no history of chest pain. Gastrointestinal system: mild indigestion, no abdominal pain. Diarrhea present for 3 days. Nervous system: no headache, dizziness. Patient is paraplegic. Negative history of seizure. Urinary system: patient is on urine drainage bag. Local examination of pressure sore was done. Ulcer is about 5 cm in diameter, almost round in shape. Position: right gluteal region. Slough present, mild tenderness, and foul smell present. Treatment and investigation: all routine investigations were done. CBC HB 10.3, TC 30,000, neutrophils 50.9, eosinophil 10.2, lymphocyte 28.5, platelet 2.8 lakhs, serum creatinine 0.9, urea 22, serum sodium 133, serum potassium 3.4, FBS 128 milligram. Treatment: wound dressing daily done, medications given. Past surgical history: patient underwent hemorrhoidectomy 12 years ago. Patient had developed abscess in the same area before he underwent incision and drainage. Medication: tab metformin 500 mg BD for diabetes, tab pandrosit 40 mg, tab paracetamol SOS, tab Imodium, Econom sachet, IV fluids. Psychological aspect: patient is paralyzed, unmarried, living with his brother. He also has 2 sisters and 2 brothers. They are unmarried and living separately. Mother and father died. His brother is a manual laborer. He is the breadwinner of the family. His brother has 2 daughters. They are 28-year-old twins. Patient is worried about his brother's family. He is also anxious about progress, management, recurrence, and complication. Self-care deficit, financial problems. The patient is a Hindu, unable to celebrate festivals and to visit friends. He is always said that does not spend money on his treatment and should be taken him to any old age home. Main concern: pressure sore, pain, diarrhea, diabetic diet, anxiety, financial problems, activities of daily living, nutrition, family support. Summary: 56-year-old male, unmarried driver, sorry, met with a major accident in 2004, which resulted in cervical spine injury. Reports unable to ambulate without assistance, mostly wheelchair bound, feels depressed due to disease process and financial problems. Non-diabetic, now presented with pressure sore, pain and diarrhea, pain due to immobility and pressure ulcer, generalized weakness present due to decreased oral intake and diarrhea, anxious about prognosis, management, recurrence, and complications. Discussion points. As the patient is paraplegic with stage 4 pressure ulcer, palliative care at home, how to take care of his wound and other physical problems, what all can be done for this patient and this family. Thank you.
Thank you, Sony, for the wonderful presentation. Anybody need any more clarification regarding this patient story? Please ask her. Otherwise, we can move on to the discussion points. I think the case presentation is clear to everyone. We can move on to the discussion points. We would like to hear from the participant side first. Today we have learned about bed sore and the management. Uh, she was presenting a patient story regarding the stage 4 pressure ulcer. How can we manage? Her first question is, as this patient is paraplegic with stage 4 pressure ulcer, how to give palliative care at home? Either you can unmute yourself and talk, or you can put your answers in the chat box. Anna, over to you.
Yes, as sister said, we would like to get few points from participants. What will we do for there will be many when you do assessment, can you tell me 4 points in each? Patient is paraplegic, so naturally there are many of the points are already given in physical problems, right? What can be his psychological problems? One point is already told, right? What was that? Patient is now going into depression. What else? Imagination. Many of the problems we have to imagine that the patient might be suffering with. Worry is there. He is not able to do activity of daily life without help. Right? So right from the morning till he goes to bed. He goes to sleep, I should say. He is always in the bed or in the wheelchair. What he would be doing? He was a driver. What was his occupation? He was a driver. So you can imagine that now he is not able to go anywhere. He is bedbound. Psychologically, he would be so much of traumatized, right? So what can we do to alleviate some of the problems?
Can I interrupt? So I would like to ask to Sony about where is he right now?
He referred to medical college for wound debridement and other thing. The family, the patient was in Anandaburi hospital.
Okay.
One temple trust people are taken him to that hospital, but he is not cooperating with us because after seeing that hospital and the settings, he know that the amount will be more.
Okay.
So he is referred to medical college.
Now he is in medical college hospital, right?
Yeah.
Okay. Thank you. Okay.
Was he referred to the medical college for possible surgery? Is he a surgical candidate?
Hello.
I think
What
patient,
is
she said that patient has come for surgical debridement. Right?
Yeah,
Wound
actually he came
debridement.
for wound debridement. That wound is already on that place before 2 years, and the IND was done. After that, the relatives are not noticed. After the patient complained of diarrhea only, they noticed that discoloration is also present that time also, so they never noticed. When he come to our hospital, the back is full of blisters and everything, and the wound is leaking. They think that is because of diarrhea, but when the wound is cleaning, it is deep and deep, and then tendon, all things are. Then the doctor said that swab also present, and swab sent for wound culture. After that, patient is not willing to stay there, so doctors are planned to do wound debridement, but not able to do that. Before he referred. Before that.
Okay, Sony. Actually, the stage 4 wound management is better to do the skin grafting, because if there is a possible of flap surgery, that is the better thing for the stage 4 pressure ulcer. Better to consult a surgeon, go for the surgical opinion. The best option is surgical management. And another thing is, if they are not willing to undergo the surgery or the slough cutting, then you can manage with maybe metronidazole powder, that kind of things. But you can educate them and what are the positive things and negative things. If they are not take care of this wound well, maybe septicemia.
I have just one more question, just generally. It said in the slides that the dressing change was being done once daily. In my experience, oftentimes it's done twice a day or as needed if it's soiled. Is that what you've experienced as well at Pallium?
Hello. Can you repeat the question again? I can't hear you. I have received a call in between.
Okay, sorry. So the slide says there's dressing changes being done once a day. For a wound that's that deep, is it better to do dressing changes twice a day? Or as needed, of course, if it's soiled with diarrhea?
Usually, we used to do twice a day. If there is any if there is any soiling there, definitely we will change as soon as possible. If there is a stage 4 pressure ulcer there, definitely the exudate will be there, profuse oozing will be there, the dressings will be wet. Maybe you can change twice a day. That is good. I think in Pallium we used to change twice a day.
Okay.
Any other opinion? Any other suggestions?
The frequency of changing dressing will depend, of course, on the condition of the wound. right? So, and how much it gets soil. So it will always go with that.
There is no actually there no need to that change it twice. No need for changing the dressings twice a day. Then once a day is enough. But if there is profuse exudate or maybe diarrhea, that kind of things there, definitely the dressings will be soiled. That time you can think about that also. Okay.
Yeah, so patient's wound must be smelling also, right? So we need to apply metronidazole. So there are so many points have come in chat box. So, right. Then what else can you do? Recreational therapy you can use, right, for the patient. He's also worried about his brother's earnings because he is totally dependent.
I think this patient is paraplegic, so better you can see a physiatry doctor, and maybe physiotherapy will be helpful for this patient, and making maybe sometimes if they are able to, if he is able to get up from the bed without support and using wheelchair. So we usually that get lot of patients like that. Our physiotherapist will how to change the. Can you hear me?
Yes, ma'am.
Hello, can you hear me?
Yes, ma'am. Yes, ma'am. Audible.
Yes, yes.
Yeah. So our physiotherapist will that train the caregivers and patient. Then when they go home, so they are able to get up from the bed without support of the caregivers, and from the bed to wheelchair, they can able to that shift. They are alone, and from wheelchair to bed also they are independent. So that kind of things, if possible, you can do is for this patient also. Then they can. He feels maybe we can maybe quite a little bit burden will less. So that can also you can think about physiotherapy, rehabilitation also. Anna,
Specifically, it was written burning pain, so that pain assessment need to be done, and related drugs can be given.
Anna, hello, Anna. I am leaving. Carry on. So my mother is not well. Sorry about that. Okay.
Yes, so patient is having burning pain, right? So pain assessment also need to be done. What kind of pain patient is having, right? Scoring and type of pain, right? PQRST you must have learned, right? So that can be done. So drugs can be added in that way, right? To reduce problems. Patient is not getting sleep, then patient can be made active during the daytime, and so that he will feel tired and then he will get sleep, right? So nutrition also patient is taking orally, right? So patient, right, sister, patient is on oral food.
Yes, sir.
Okay, so what kind of diet can be given? patient has been undergone surgery of hemorrhoidectomy, right? So patient was tend to get constipation. Maybe we can think so, right? So diet care also should be taken. Patient should get adequate fluids, right? What kind of diet you can give to patient?
High protein.
Yes. Then good in vitamins, right? Then roughage also need to be taken care of, right? To avoid any constipation. Patient toileting time and that also needs to be done. Adequate care should be taken in that. Whether patient is using a chair or bedpan or what, patient is able to, and patient is diabetic also, right? So diabetic diet also is required, right? So what to avoid, what to take, local resources we have to use and advise. Wound management we have seen, right? Physiotherapy also, sister told that patient need to do. So with the help of maybe if patient is in the hospital right now, so he can be taught what exercise can be done and simple exercises. And when he goes back, again that burden will be on caretaker to get here exercise done from the patient. So additional things will pile up, right? So help can be sought if anyone is coming at home. There are services available from hospitals and privately also. Of course, we need to see to it that how much patient can afford, right? So all points need to be considered and then only advice, right? Otherwise, relatives only will be uh, doing that work of physiotherapist also. Okay, what else? Social burden. Social burden is mostly patient is having economic problem, as it was said in the slides, right? Then patient is not able to go out, right? On his own. He is dependent on the relatives for going out, right? So you can, what you can do? Ask the family members, distant family members to come and meet patient. Of course, that will depend on the relatives' conditions also, right? Okay, so these are, I mean, some of the points which we can sort out. If you have home visiting teams, then that home visiting team can also pay a visit at his house, right? Once the patient gets discharged. What about the spiritual needs? Patient must be angry at God, right? Or patient maybe he is not able to take part in religious activities. It is as it appears in the slides, right? So he must be feeling very embarrassed also. He's not, he might be thinking that I am cursed because I have not done enough bhakti of God, right? So those things, so we can always take help of even religious leaders also, right? That some puja has to be done, he can be taken out or not, or it can be done at home or not, right? All the possibilities we have to find out. He is able to sit in the wheelchair, so at least he can go to nearby temple, or in the house if the temple is there he can pray, all sorts of things. So all this assessment we have to jot down the points under different headings and talk with the patients and relatives, right? So basically in palliative care, what we do is we try to let them say what they want, how much they are doing, what else they can do, and then we advise. Okay, problems will be told by them, and their solutions also identify the factors, I mean, which can be helpful to them, right? So with the help of the patient and family, we have to suggest best possible things for patient and relatives. Okay, so those points we have to remember. We should not impose our ideas on them. Okay, we can only facilitate what they want. That should be remembered. Anything else? So many things to learn in palliative care. We are just doing our bit, how we can maximize our help to the patients. So that is our try. We try our best. And we get encouragement from each other, right? So always keep your minds open to learn new things. That is the best thing. Okay, anything anyone wants to tell in this case, or should we wind up?
Thank you everyone for joining us, and also thank you Anna ma'am for a wonderful presentation. Thank you.
Thank you. Thank you so much.